has been at Greenstone Clinic with me since her last placement as a student nurse back in 2010, and she's on the nurse practitioner route doing her final year next year. Hopefully she's going to get one of Jonathan Coleman's 20 funded places. So Jess, over to you.
Kia ora tātou, my name's Jess, and like Karen said, I work down at Greenstone Family Clinic, which is in Manurewa in South Auckland. I'm originally from Tauranga, that's where I grew up, but have lived in Auckland ever since I studied and now work at Greenstone. And I do feel like a little bit of a fraud standing up here because I'm certainly not an expert in asthma by any sense. But Karen and I wanted to share with everyone the journey that we'd had over the last kind of 2.5 to 3 years as we try and manage asthma for our children, in particular our under 16s, within a general practice in a way that's slightly different to what has been done in the past. So it's probably not the most academic 30 minutes, but more a story of where we've come from. This is Karen's slide.
Okay, do you want to just go back to what you're going to talk about? No? Okay. Okay, so just to give you a bit of idea of where we are, Manurewa is South Auckland. It's probably one of the poorest boroughs in the whole of New Zealand. Child poverty was, when I last looked at the stats, child poverty was around about 69%. We've got 27% of our families are one-parent families. You can read those stats. Our enrolment is 33 to 35% Māori families or patients, and 28 to 33% Pacific people. So we've got a high Indigenous population in our enrolled population of 5,200. It's a fabulous area. It's very multicultural and enjoyable to work in, but it can be quite challenging at times too.
Some of the statistics that I was reading, because Counties is known to be a community that has a high Māori and Pacific population, and of all the Māori living in South Auckland, 46% of them live in Manurewa or Papakura, and of all our Pacific people, 77% of them live in Otara, Mangere or Manurewa. So it's a really interesting population to work in, and it's really young as well. So this might be a silly question to ask now after everything that we've learnt today, but why would we change the way that we're already managing asthma? So for us, it began with our practice partners, our GPs, kind of subjectively thinking that maybe they were seeing some really poor control in their children that were coming in to see them for issues like running out of inhalers, incorrect use of inhalers. So it started with the GPs kind of identifying this problem when they're seeing the children, and they felt like they were getting more letters from Middlemore as well to say that the kids were presenting to the emergency department. I think it moved on from that, kind of thinking about it and talking about it, to becoming an idea because of Karen. So she's not just a nurse practitioner for children and young people, she's a real kind of champion for children and young people's health. And so she felt really strongly that actually we had, because of funding models or other reasons, we'd actually failed to do chronic condition management in children in the same way that we had as adults. So we wanted to devise an innovative way to do chronic condition management in children, to be an example as to how it can be done. And I was coming through at this time that all these discussions were being had as a young nurse, and I'm a good example of how an N of 1 or a single case can change your perspective on a problem. And I remember I just started at Greenstone and I saw these two cases, or saw Amy, heard of Mary. And Amy was a young 12-year-old girl who was coming almost monthly to the GP, breathless, waking at night, missing school because she was wheezy, and just really generally miserable. And each month she would say, I've run out of inhalers. And we would give her more inhalers. We'd give her a 3-month supply and she'd come back in another month with no inhalers. And what we eventually worked out was that It was free for Amy to come to see the GP, but it wasn't free for the adults in her broader family to go and see their doctors, so they were shopping at Amy's house for her inhalers, and while Nan was trying to protect her supply, the adults in the family were taking it away. Like some of their aunties in particular. And then Mary was another young girl she was a bit older, she was 14, again ran out of her inhalers, and didn't have anyone over the weekend to take her to the emergency department, so jumped on a train in Manyarewa to get to Middlemore, and I think it's about 20 minutes on the train. And by the time she got to Middlemore, needed IV treatment for her asthma flare, and she was by herself on the train. So you see cases like that and you think actually we need to do better and we need to do different. And we've already spoken about the fact that it is an equity issue, and I think we've been through all of these statistics in pretty much every talk that we've had today. These are the ones from the Isaac study. And in particular that our Māori and our Pacific children have more severe symptoms. And so the Isaac study looked at 6 to 7-year-olds and 13 to 14-year-olds. So in our younger children and our older children, both was seen. I'll just check.
Yeah, and this is just, like Jess said, just pushing the equity issue. Actually, this is the work from the Paediatric Society who do the epidemiology service. The Paediatric Society fund the epidemiology service down in Otago that Liz Craig started, but she's handed it over to these guys now. And just to show that asthma and wheeze, of all of the hospitalisations, this is the highest, and it's disproportionate, as we know, for Māori and Pacific Islanders. So 15.4% of all hospitalisations between 2009 and 2013 were for asthma and wheeze, and it's a condition with a social gradient. So just pushing again that it's social gradient, that it's the poorest children that end up in hospital. So we work in one of the poorest areas and we wanted to do better for our children. And I am, as Jess says, absolutely passionate about trying to change the stats for children in this country, because when you look at the OECD stats and where we sit, we're embarrassingly right down low in the whole table. And like Ines Asher always says, you know, we pride ourselves on the Rugby World Cup and how well we do in rugby. Why can't we get our children's health up there with the Rugby World Cup statistics? So back to Jess.
So we decided to look within house at how our children were doing back in 2013, and I'll just preempt, so we're going to show some graphs and some numbers. This isn't any sort of study, there's no kind of significance or power or anything like that kind of calculated. This is just purely our raw statistics so that we can talk within our team about how we're doing and improving. But I thought it was interesting to share with you guys as well. So we've got a team of GPs, practice nurses, midwives now, NPs, who are all really passionate about working within this community that we're all really fond of, and many of us live in or near. And yet, when I looked at our data, the exact same thing that was happening within those big kind of Isaac studies and the Ministry of Health documents were happening within our house as well. So this is from August 2012 to August 2013, and I went back manually through our PMS system and tried to pull some data, and I was really lucky to have the time to do this through my study, and I understand that many practice nurses wouldn't be given that opportunity because it does take a wee while. But so we had in this kind of time period, we had 11 presentations to Kids First for asthma, wheeze, and then other kind of respiratory conditions. So if they were kind of classed as an URTI, we counted them as well. Of those 11 presentations, 7 were Māori, 2 were Pacific, 1 Pākehā and 1 Asian. And then when we looked at our out-of-hours care presentations as well, we had 14 presentations in the same time frame, so from August 2012 to August 2013. So 14 presentations, and 12 of those were our Māori children. And this is in a practice who, we pride ourselves on really good care, and we thought we were giving really good care, but until you look at the numbers, you actually can't be sure. So because I was studying, I had the opportunity to go away and to kind of have time to think about what we could do with these numbers. So our goal was twofold. We wanted to make things, we wanted to decrease our number of hospital admissions, but we also wanted to decrease that gap, which might have been a massive goal to have, but that's what it was. So I started to read about what would work, what we could do, what was the best possible care that I, as a young nurse coming through, could give to these families to try and change this this picture. So this is a Cochrane review that I read, and it was relatively large. It was 38 trials and 7,800 children, and the intervention was any sort of asthma education, and the population was children who had attended the emergency department in the previous 12 months, so it wasn't necessarily an admission but any presentation, and they had what was considered an educational intervention varied considerably based on who gave the education, where it was done, when it was done, and by whom, and what form it took. But when they gathered all these studies together, it showed that educational interventions in this particular group would decrease emergency department visits, decrease hospital admissions, and decrease unscheduled doctors' visits as well. So the next place I had to go to was, well, what kind of education will we give? What would we include? And I read the sign guidelines from start to finish. And I pulled from it the things that I had influence and power over. So obviously there was a lot of kind of medication titration, things like that, that were very interesting and important. But I wanted to pull things from it that we could really influence. So these were the things that we pulled from. And the reason I really like the sign guidelines is it does have a little section on how to implement systems for people with asthma, which I thought was really helpful. And in the sign guideline it mentions that all people should be given some sort of self-management education that should be backed up by a written asthma plan, and it did talk about the fact that symptom-based asthma plans were probably better than the peak flow ones for children, which we've talked about as well. But it also talked about the idea of this asthma register, so having a list of known asthmatics kind of on an active register. So that's where we kind of got the basis of our ideas from. But then, so I had this plan of an active asthma register, and everyone was going to get this education, and we were going to back them up with care plans. But how do we do that in a small to medium practice? So we've got 5,000 enrolled patients, 4 practice nurses, an NP. How many doctors? 8 part-time doctors. So the first place I started was with what we were already doing, which was diabetes management in adults, and that idea of a Care Plus kind of system, a 3-monthly review, those sorts of things. But the funding for Care Plus was changing for us at the time, and so I had to do a business plan, and it became very apparent that if we got 80% of our children to come and see us nurses for their asthma care, we also made the assumption that that wouldn't reduce GP visits, because when we looked at our reasons our children were presenting to the GPs, it was never for purely asthma. Children come with a myriad of complaints usually, because mum's taken the afternoon off work to bring them. So we made the assumption that if the children came to see us nurses, it may not reduce the number of GPs visits, but it would increase the number of nurse visits, as well as GP time if they were expected to do the prescriptions within the chronic care consults, as well as recalling and auditing and those sorts of things. So it seemed at the time that it was a little bit cost prohibitive. So then I started to look laterally as to how could we piggyback on systems that were already there. And I think someone mentioned before, we already recall all these children at flu vaccine time. So we're already kind of reaching out to them then. So what we thought we could possibly do is really focus on the annual asthma review, where they get really good education and then are encouraged to come back and see their GPs if they're well-controlled asthmatics. And if they're poorly controlled asthmatics, then they kind of get identified on that list for the nurses to keep an eye on. And when I calculated the costs, that would cost a fifth to the practice of what the traditional chronic care kind of model would cost. And that was really important for a couple of reasons, because there is a fixed kind of funding, and so whatever you do has an opportunity cost. So if I want to do this, that means one of the other nurses can't do whatever they're passionate about, because there's not just asthma where there's massive inequities, it's everywhere, it's rampant. So the idea was that at the start of winter we would send everyone an annual asthma recall letter that encouraged them to come in and get their asthma checked. We kind of marketed it like a warrant of fitness, and the idea would be that they'd get really good education, they'd get an asthma management plan, and they would get the flu vaccine if they wanted. But we made the flu vaccine an optional part of that, or kind of downplayed it in the letter, because we didn't want families who didn't want the flu vaccine to then not come in and see us nurses. The other thing that we kind of wanted to focus on was us nurses being really good at... Oh, sorry.
So how much response did you get from the letters?
I go into it later on, but letters aren't great, I think is what you're probably getting at as far as getting families in. So we started with letters and followed up with phone calls, because they just work better. But the other thing that we did is try to do everything really opportunistically as well. So if the child was in for another reason, or if a family member was in, so dad was unwell and he'd brought the child with them, our nurses were really fabulous and flexible about saying, hey, could I have half an hour of your time to talk to you about your child's eczema while you're here with your asthma. Oh, sorry, I also run an eczema clinic, so every now and then I fall back into eczema. We're here for asthma, after you've had your gout treated. So that worked really well, and so that meant, one, that the recalling was minimised, so the cost to the practice partners was minimised, but also that a booked nursing appointment wasn't the only way that these kids could access care. So we were trying to decrease some of those barriers. So we created the list, and the way we created the list was anyone who had been given an inhaled corticosteroid script in the previous year and had a classification of asthma, and then for any that were missed, the doctors would send me tasks just to notify me. It's not the perfect way to start a list, but it seemed to work really well. And so this year we generated 107 children for that list for our active eczema register. Like I said, we substituted the flu vaccine recall, because that was a way we could recall all these children for essentially a zero cost. Training up of our nurses to deliver the asthma review, and then I think the opportunistic appointments was the thing that worked really well, because it took the onus off the family to come in, and it made it upon us to make the time. So this is a little screening, this is certainly not as flash as that lovely GASP tool we were just learning about. So this is, for people who don't work in primary care, this is our PMS system, or one of many of the PMS systems, of the couple, sorry. So this is what we use in the clinic, and we just basically made a little checklist of things as a reminder for the nurses. I think nurses quite like, I quite like checklists. But it also helped to gather the data. So it's really simple. The nurses would start with assessing symptom control. We used the ACT, the asthma control test, because that was one of the things that the SIGN guidelines said was a good thing to use. It also was low cost, because the drug reps can give you pads of them for free, so you don't have to worry about printing. Obviously they'd assess height, weight, peak flow. We'd also, with the older kids, talk about inhaler preference, because we'd read that maybe Acuhalers were better in adolescence as far as compliance went. And then it's just little things. So it's check boxes for checking spacer technique, medication review with the GPs, talking about smoking cessation, flu vaccines, and Starship. We chose to use the Starship plan. So this was the way we focused our nurses on the things that we had read that would from that sign guideline. And we chose to use the Starship plan because it didn't rely on anybody's handwriting, but also I like the emergency kind of stuff down the bottom. I think it's really clear when you go through it with families exactly when they need to do that. And you can also, sorry, this one isn't completely filled out, I realised after I made the slideshow, but you can also add things here. So we would kind of personalised messages to the child, but basically it was to say, come and see Nurse Jess, come and see Nurse Leanne, you know, if things are getting worse. Is there anything you wanted to add? Oh. No, that's beautiful. So just in the last few months, we've started to look at our progress. Have we improved? How have things changed? And again, you know, these are small numbers and some of it could be due to chance. It's certainly no sort of research trial, but just an audit tool that we use to kind of have discussions with our doctors. So the percentage of our children on our active asthma workbook who have got a recorded and up-to-date asthma management plan in 3 years increased from 2.3% to 65%. So we're doing better. This might be
107 children.
Yeah. This might be partially an issue with capturing it, because if it sits outside the PMS system, sometimes obviously it never makes it back there. These are our flu vaccine rates over the last 3 years. So we were sitting at 39%. So this is in under 16-year-olds because that's where we focused. But we were sitting at 39% and we've shot up to 59%. But I think what this masks is our improvement within our ethnicities. So for example, our Māori flu vaccine rates increased from 42% to 72%, and our Pacific ones from 36% to 68%. People having their spacer technique recorded in the system increased from 8% in 2013 to 57% in 2015. So this is of all the children. So some of them we couldn't get into the clinic, and so obviously that drops the stats. Having a documented peak expiratory flow in the previous 3 months increased from 30% to 61%. I don't think we capture smoking status in our children as well as we do in our adults with the way that our dashboard system works. So I looked at how many children had an unknown smoking status, and that decreased from 84% to 47.6%.
That doesn't mean that they're smoking, it means that they're living in smoking households.
And I think this is where the nurses excelled this year, that 100% of our children who were recorded as smoke exposed, that either the family got brief advice, or if it was the child or adolescent smoking, then they got the brief advice. So I thought that was really cool. And this is our number of children presenting to Kids First under our active asthma program. So like I said, in 2013 we were sitting at 11 and we've gone down to 6. And this could be for a number of reasons. I think in the last 2 years we've really strengthened our acutes clinic within the clinic. So we, children who are unwell on the day are seen on the day and not turned away. Also, I think co-payments for medications have been increased from under 6s to under 13s. And our population is really transient as well. So it may be that some of our really severe asthmas moved out of the clinic and some milder ones came in. It's hard to know. But it may be that what we're doing is working as well. And of these 6, 3 were Māori, 1 was Asian, 1 Samoan and 1 European.
So would you say the way you reorientated, the way you did things made that change? I know you can't.
It's just so hard to know. I think when you're invested in a program that you've worked really hard on, you want to say, we did this. But there's so many different factors that could have influenced this. I think what is important is that our kids are going to hospital less. But like I said, it's small numbers, so it could just be chance. But I think in the past 2 years, the focus on asthma for all of our population, not just our children, has really increased. So we're constantly kind of asking, how come? Yeah.
You may not have captured that, but you may have influenced further in the process.
Yeah. And we're starting to get some really lovely feedback from our patients as well, which is really important. And this is a little bit of a braggy slide, sorry. But this is a family of a young girl who was recently in the Herald, and it was an article about the changes in the co-payments to medications. But she had been to Middlemore twice, out of hours 10 kind of times, although not all of those would have been for asthma flares. And we were seeing her really regularly as well on an acute kind of flare-y type basis. And her mum told the reporter from the Herald that because of Greenstone she felt her asthma was really well controlled now, so that was really cool. And the family actually saw Leanne this year, so she did a very good job. But we are starting to get some feedback that people are appreciating it, and I think that's important as well. So I think this year went much better than last year, which went obviously was much better than the status quo in 2013. And when I was thinking about it, I think these are the reasons that it went really well. So there was the flexibility within the nursing staff. So even if they were rostered onto paperwork or phone calls, they were willing to come out of that kind of system and see these kids to make sure that they didn't have to come back to be seen, and that was really important. I think that the nurses involved, so we had 3 nurses and Karen, the nurse practitioner involved, felt really confident with their asthma management, and I think that came down to 2 things. It came down to the fact that we've got really supportive GPs, and I think that that's really important. You know, for nursing to develop and strengthen, we need supportive GPs as well. And so our GPs were really using this whole program as, you know, every time we saw an asthma child, it was an opportunity to upskill us, to learn something new, to bounce ideas off each other, and I think that really gave the nurses confidence. And also the screening template was quite handy because it meant that, you know, if you lost your way, you had a checklist to come back to and make sure that you covered the really important elements. The other really good thing about having a screening template, if you are using a PMS system, is that it allows the auditing to happen much quicker. So in 2013, I was lucky to be studying because that audit took me days and days and days, and I think we went through 210, the equivalent, so we had 210 children and a year of notes. So it was 210 years of medical notes to read through to pull that data. Now with the screening template, it took hours and hours rather than days and days. And hopefully as we get better, it'll take minutes and minutes.
You're also using the dashboard down south?
Yeah.
And does your screening tool follow from that? Have you got it programmed in?
I've got it programmed so that if you update the height, weight or peak flow in that screening template, it automatically updates it as it pre-populates into the usual screening template for height, weight and peak flow, and therefore it will populate into your dashboard. We've
Come back up as
A prompting reminder that this is now...
Oh, the actual asthma review itself, no, the measurements within the screening template will populate back to the dashboard, but the asthma review itself won't. And it's really hard. We don't use dashboard anymore. We've moved away from dashboard to the BPAC tool. Yeah, but both. I mean, it's really hard to get anything changed on them because they're PHO wide. Yeah, and both have pros and cons.
I just had one question about nurse training. What kind of training and who did it? Did you do it like an in-house training?
Yeah, it was mostly in-house. So we had a system, we don't have it anymore, but we had a system for a little while where us nurses were paired with a GP, and so we'd have one-on-one training, and then as we would move around the GPs based on their kind of special interests. I did...
You did the asthma course, didn't you? And asthma New Zealand.
I didn't do the Asthma New Zealand one. I'm trying to remember what I did. I did something. I did the Goodfellow one. And then I also did a paper on my clinical project paper was on asthma, so we did a lot of research on asthma, but that wasn't particularly clinically focused. That was more on kind of guidelines and research.
Sorry, would you mind if you practice more when your practice is screening template for asthma? It's really good. And it's really clever of you to piggyback it onto the flu vaccine, because that's a way that every asthmatic gets a free consult within us every year that's already paid for, and there already is we call set up for that. That's running.
No, we're very happy. We're on a university practice, so, well, I mean, it's just 3 of us work at the university as well. So, yeah, so we're very happy to share whatever we kind of do. You don't mind, do you? Even though it's your intellectual property.
No, I think it's the practices if I do it when I'm at work. And what we built in a recall.
Sorry. Have you got
It's very hard to read.
It's hard to read.
Okay, what I'll try and do is get.
I could do a screenshot of it,
Yeah.
like just send through the
and send
screenshot
it
if you
to
like.
Erin and she can send it round everybody.
And what we did to try and balance cost and make sure that the children who were most at need were getting the care is that we varied the recall. So we've got, so for a family that seemed to have really well controlled asthma, that had that were already being seen by the GP for regular reviews, we were pushing the recall out to a year's time, encouraging them to come back to see their GP for their medications, but saying that this would be an annual kind of update that we'd do to redo the education. For the kids that we were worried about or who had poor control, we would alter that obviously, and it varied when you could. We kind of we didn't really have a protocol for that. We left it to clinical judgment, what the GP and the nurse decided together. So there were some kids we were really worried about that we would say, come back and see me in 2 weeks' time. Because I want to see if you've got that spacer technique down yet. There were some kids that you'd just do a 3-monthly review, and then you could just give them a call then and say, hey, it's time to come in and see your doctor, get some inhalers. So it varied a lot. We kind of didn't protocolise it too much. The other downfall of that.
But initially you tied it all to the flu vaccine at the beginning of winter.
Yeah.
Initially.
Yeah. So I'm trying to remember what date we sent the recalls out. It's usually end of July, isn't it? No. No, May.
Yeah, it's usually May.
May, yeah.
It was later this year because
Yeah.
Oh, it was delayed, wasn't it? Yeah. What was I going to say? Oh, the downfall of a screening template is that if you miss something off it, it doesn't get captured and doesn't get recorded. So I didn't put the warm-up homes, which is our version of the free insulation program. I didn't put that on here because I thought it would be captured in here. But what we realised afterwards is that if they didn't need a referral, then it wasn't captured that it was talked about. Does that make sense? So that broke my heart at the end of this year when I did the audit, because I thought, no, we should have put that in there definitely. So that will be altered, so put that on yours if you use it. Oh, that's a good idea. I think, that was all.
I think just talking about funding, what we've done in our practice now is, ARI, everybody's got ARI, haven't they?
It's counties only.
I thought it was Ministry of Health.
No.
what does it mean?
At-risk individual, so you get,
It's a great name, eh?
yeah, it's taken over from the chronic care, funding. So what we've done is put our at-risk children onto these programs, which means you can go out and do home visits on them as well.
That's something that's really different about New Zealand and in the UK. Like people you were really worried about, you tend to visit at home in the UK and you know what's going on.
That would be particularly hard in Waihi, because I'd imagine you'd have lots of rural kind of. Yeah.
Okay. Any more questions? Anybody?
I think because we were talking before about when is the PHA going to fund things like this, and I think that's one of the things our practice decided is that we can't wait for that to happen. We need to model these sorts of things, and then, you know, we're really lucky in the fact that we've got people like Karen who've got lots of influence, but we can then take things like this and say, hey, look, this worked really well. Would you like, you know, to roll this out, to use it as an example? It's really hard though.
It's really hard changing people's behaviours, isn't it? But, you know, we think it's kind of important to look after children. I mean, one of the things that I battle on about is I think all children should be seen for free in general practice under 18, not just under 13. And also the other thing is that we try and have a policy that if a child comes for a consult, that if the family owe money, it's not raised at the child's consult. You know, it's for the child. It's nothing to do with anybody else in the family who might have a debt with the practice. So that we really are trying to uphold that UN Convention on the Rights of the Child to get the best possible healthcare. So, thank you, Jess. That was brilliant.